Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health. I'm Joshua Sharfstein, Vice Dean for Public Health Practice and Community Engagement, and a former health commissioner here in Baltimore. Our goal is to bring evidence and experience to illuminate critical public health issues. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
Hi, I'm Lindsay Smith Rogers, producer of Public Health on Call, and today we're back with the Public Health on Call book club. Dr. Josh Sharfstein interviews Dr. Thomas Fisher, a Chicago emergency room physician and the author of a new book on America's ongoing health crisis. Let's listen.
Dr. Thomas Fisher, thank you so much for coming to Public Health on Call to talk about your book, which is The Emergency, A Year of Healing and Heartbreak in a Chicago ER. You wrote this as an emergency department physician during the COVID pandemic.
I did. Thanks for having me on, Josh. It's exciting to have this conversation. And you think back to 2020 and when so many things were stripped away from us, from our ability to go to a restaurant and watch basketball games on TV or just spend time with friends in public spaces, that left a lot of time to do other things, which is included writing this book.
And the book is interesting because you both talk about what you see in front of you and what's behind what you see, and you illustrate your points with letters that you could write to the patients, for example, or others that you encounter.
Mm-hmm. Yeah, I wanted to do two things with this book. One is bring the reader into the intimate, special relationship between physicians and patients, one that's really unique in society, where people are sharing these moments that are just very unusual and create a level of intimacy between strangers that's rare. It sort of reminds me of something that happened about 3 weeks ago. I was taking care of an elderly person who collapsed at home and suffered cardiac arrest. They were transported to me in full arrest, and while we had a couple of episodes of return of circulation, they ultimately died. And after we had our moment of silence, my next step was to go talk to the family. And I go into the family waiting room and I have this, process. I've been doing this for 20 years. And so I sort of know what I'm going to say. And I go start my process with an introduction and ask what they saw, etc. And there comes a point where this gentleman, it was one of his parents, this gentleman stops me and says, "Dr. Fisher, don't you remember me?" And I'm embarrassed because I don't. And here I am having this very intimate conversation with somebody who knows me, but I can't say that I know them back. And he says, "Yeah, we had this conversation in this exact room 4 years ago when you pronounced my other parent dead." And it just brings into relief how intimate and important these relationships are in the experience, even in the emergency department are, even if they're fleeting, they're only for a moment. But for these individuals who you're working with, it's a before and after event, something they never will forget, whether they're a family member or a patient. And I wanted to make sure that the book brought people that level of intimacy to understand the core humanity of the people who come to you for care. And then I wanted to write letters to many of those patients to help them understand the broader systems at play that brought them to the emergency department, either as a family member or a patient, with issues that, while they think are specific to them, I see in broader patterns and understand in a context of society. And that's hard to do. And so what I tried to do is make it real simple by just saying, like, if I actually wanted to sit down with somebody who doesn't know anything about healthcare, but is interested, what would I tell them? And so it became letters.
And those letters talk a lot about the failures of systems that led to the tragedies that you see in the emergency department. And maybe it would help to describe a little bit about the emergency department you work in and the kinds of failures that wind up coming to your door.
Yeah. I work on the south side of Chicago, which is a very big community. There are about 1 million people on the south side of Chicago, while largely Black Americans. Of course, there are white folks and a ton of Latinx folks who are largely Mexican. But we're situated in a mostly Black community, and we're both a trauma center and an academic medical center, and we see a high volume of both everyday challenges, people with the random events of life. Tripped and fall, broke my wrist, fell off my bike, hurt my elbow, to the catastrophes that transform lives like strokes and devastating car accidents. And, we also are the busiest trauma center in the state. And so we see all of the young men and women who have been perforated by bullets. And we also serve some of the most underserved, racially marginalized, and challenged communities in the city. And so we see untreated chronic disease, people who are sick well before their time, and those who have nowhere else to go for help, even if that help is not necessarily medical. So we're at all times quite busy.
So you see these patients coming in, untreated chronic illness, and there's some great examples in your book, victims of violence, and you take care of them. You can be frustrated in the book about some limitations in the care you can provide them, and you're also frustrated about some of the conditions that led them to come in.
I think when I was early on in my career, I had this notion that the distribution of resources, which are unequal and unjust, were simply a broad misunderstanding. And with clear-eyed work and research, we could redistribute them towards more equitable solutions where people who need the most get the most. And I think it took me a career to understand that we have systems designed well before our time that don't require that we are good or bad, but simply by going along, we recreate many of the injustices that exist. And that means things. And so what that means is when we get sick, which we all do, few besides the wealthiest will be able to afford their care. And so that even in the best of conditions, the jobs that offer these private insurance are disproportionately held by people who are already healthy, they can work, wealthy, and white. I mean, I think we know the research pretty clearly describes that Black men with college degrees are less likely to be employed than white men without college degrees. So in cities like Chicago that have a legacy of segregation that extend back many generations, these Black folks who are less likely to have desirable private insurance and are 50% more likely than white folks to be uninsured are then crowded together into communities with high rates of Medicaid or without insurance at all. So in communities around my hospital, like Inglewood, which is kind of notorious for its violence and poverty, about 12.5% of the folks are uninsured compared to the North Side's leafy, green, and wealthy Lincoln Park, where only 2.5% are uninsured. And if you were to lay a map of where our healthcare services are, we're on top of that map of segregation, you would see that providers are concentrated in these areas where people can richly compensate them for the services that are being provided. It doesn't require that an administrator actually hold negative views about Black folks or positive views about white folks. If they merely follow the economic incentives, they're going to create this unjust racial distribution that capitalizes on this social sorting that has happened from segregation decisions that were policies made in the 60s, 40s, 30s. All that's required is that you're oblivious to it or willing to turn the other way in order to solve the bottom line. And so what that means is my patients often have nowhere else to go for their chronic conditions. They're often unemployed or employed in jobs that harm them. They tend to be acquiring chronic diseases earlier. They run a gauntlet of jobs that harm them, food deserts, foods that sicken them, bullets that fly in every direction. And as a result, we're busy as heck and have few resources to give everybody what they need in a timely fashion. And so I'm often frustrated, and so are my peers, by our capacity to do what we've been trained to do.
Yeah, I read parts of the book. You are telling yourself, but also wanting to get across, this is why things are like this. And it's not, random that this has all happened. You have at times in the book, suggested that the hospital itself is a place, where people come to be treated, and a place that, you hope can push back against some of those underlying forces. In your work, you're obviously doing that, but you don't always feel the support of the whole hospital in doing that. And to an extent, the hospital is subject to those same forces that you're talking about. And at one point, you describe a plan to set up 2 emergency departments, one for the paying privately insured patients and one for everybody else, and how betrayed you felt with that proposal.
I guess we all want a more just and equitable system or at least to be able to do what's right in the moment. And I would extend that grace even to the administrators who set up those systems. I would love to believe that they weren't thinking the 3 steps ahead to recognize that given how we've sorted the access to good paying insurance, that would have an explicit racial component to it. And our segregation built on top of that would mean that by dividing the emergency department by insurance, you would also be dividing it by race. Like, it takes a certain amount of both willingness to look hard at these problems and sort of historical understanding that I don't think is a part of our education. It took me years to learn it on my own. It wasn't a part of any class. I also think that folks who are delivering care really want to do what they've been trained to do. They really want to take care of all those sick people in the waiting room. And so when there are these obstacles to that, there's a sense of frustration and helplessness of moral fatigue that mounts, that hopefully motivates folks to do something, but I think too often motivates folks to resign and give up and throw their hands in the air.
So I want to talk to you about the path forward.
Yeah.
When you have a break in patients, I know it's not that frequent. If your mind wanders to what could be done to address some of these underlying issues, where does it go?
This is tough, right? I think that there are 2 levels to this conversation, right? I think that the first level is an understanding that we're going to need a grand reorganization that elevates our shared humanity over profit. One that recognizes that, look, in a city like Chicago, the way in which we've structured our system over generations means that there's no mercy for Black folks trying to live. Black folks make up only 31% of Chicagoans, but they're 80% of those who are shot and killed. We have children in Black communities have the highest blood levels in the city. In a neighborhood near my hospital, Washington Park, 15% of its residents are disabled compared to 4% downtown. Black women have low birth weight babies 3.5% of the time in another South Side neighborhood called Woodlawn compared to 1% of white folks in Lincoln Park. Like, you don't fix that with a single policy proposal. That is a re-engagement of our core humanity and having a democracy that reflects this shared understanding that we all deserve the opportunity to live, that we see in one another this fundamental component of ourselves in common, and that needs to be honored in the goods and resources that allow for us to be healthy, because it is our health that allows for us to connect to one another and to love and to hope and to connect to the infinite, right? So that, I think, is one level of solution that we need, and one that I'm not confident I'll see in my lifetime. And so that leaves us to, like, what are some technocratic solutions that we might do in the meantime to just stop the bleeding? Right? How do we just make it better in our local setting where we're not part of the problem, but we're part of the solution? right? And so I think one level of that is just being honest about how these neutral financial decisions have broad implications if they're perched on top of an unjust society. Like, what are the second and third order implications of a decision to put an insurance filter on access to our healthcare resources? They're not going to be racially neutral. And in fact, you could argue that they're not neutral at all, even if they weren't racially neutral, because we should be giving these services to people based on need. I also think we can be using data, interestingly, in order to ensure that we're looking at many of the things that we understand as important quality outcomes and ensuring that we're evenly distributing them. What's our door-to-needle time in the emergency department? And does it matter about your insurance status if you meet that? What about your race? Are we actually following through on these tenets of quality that we're intending to do? What about our thrombolytics and stroke? How often do we meet those times? And does that vary by payer status and time of day and racial makeup?
Mm-hmm. There's no shortage of opportunities and really necessities for change.
I think so. And I wonder, as a public health professional, somebody who has been leading in this way for so long, like you have, Josh, what do you think the appetite is in our public health communities and in our healthcare communities for these sorts of, this lens on what's going on and this sort of change?
Well, I think that this conversation is happening more than it has in the past. You do see more discussion of the need for equity in healthcare access and outcomes. But that discussion bumps up against some of the realities that you're talking about in the structures of healthcare payment and financing and beyond in this country. And, where that can be pierced, I think there's a lot of potential for improvement. I agree with you that there are a lot of people who'd like to see things improve. But you have to really think about changing some of those structures, changing some of the ways, for example, that hospitals are reimbursed or emergency departments are reimbursed, the kinds of things that they're held accountable to. And, it kind of depends on the day whether I'm feeling like there's some room for optimism or, not. You wrote something in your book here, I'm going to quote, I have no reason to believe that any of this can or will change, but I don't know what else to do but to keep trying. And I circled that and wrote an exclamation point in my copy of your book because, on a particular day, some of it seems like it might change. You do see some positive signs, but it's a huge hill to climb. And I think your book is a terrific explanation of how much is at stake, not just for individual people, but for our society as a whole.
Yeah, thanks. And if nothing else, I hope that we can find sanctuary with one another with these difficult truths, as opposed to seeking a comforting salve of something that's not actually honest about what's going on. If we're going to persist and if we're going to face what really is required for us to, honor these healthcare bonds and fundamentally transform everything from how we live to our payment structure, that's going to take a long time and it's going to be difficult and uncomfortable. And so that's going to mean it's going to require community to carry us through that. And so if we can't solve it today, at least we can remain in community of those who are not giving up and are trying anyway.
Well, I think your book is absolutely critical to helping people think about the challenge that's in front of us and how to create that community. Thank you so much for coming to the podcast to talk about it.
It's my pleasure. I hope this is the first of many conversations.
Public Health on Call is produced by Joshua Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmond. Audio production by J.B. Arbogast, Holly Cardinell, Spencer Greer, and Matthew Martin with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo. Social media run by Grace Holes Fernandez and Amber Bryan Singletary. Thank you for listening.